please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
What happened?
Just got back from the pet emergency room. He's on some tramadol right now, so he's a little wobbly. He had a very large hematoma. His ear was like a hot air balloon was inside of it. I've never seen anything like it in all my years of being a dog owner.
Did somebody bite him or a bee sting?
I thought it might have been a bee. We have a ton of bees in our backyard right now, but he gets springtime allergies just like his mom. And apparently with all the ear flapping, it created just enough trauma to make those two little thin pieces of cartilage in his ear blow up. And he had about 4 syringes of blood drained, but he will be okay. He's just drugged and he's wrapped and yeah, it's got a gross infection in there, but it could have been worse. But if you see me dodge out, it's just to get the wobbly dog settled again.
It's okay. That works for me. Works.
But it's been like too long since we have so much to
Phoenix.
Yes.
Phoenix. Do you know what I did today? Like I just came screaming in the door.
I know what you did, but please, I'll let you share with everybody what you did.
Everybody. People have been asking for a really long time, like years, whatever. How do you do a physical exam?
Yeah.
And you do a physical exam like they taught you in school. But it was really fun because I grabbed Wendy Bauer out of the office and said, hey, you're hypermobile. I need to be able to demonstrate how to do a Baton exam. Yeah. So come on to the office.
Perfect.
I ended up using her for the whole thing. And we went through, and she had actually a history of 2 auto accidents. And I was able to put together how you match the physical exam to the history to the treatment.
Excellent.
So it's like when I did all the dermatomes with the little pokey wheel, there was one shoulder where it was 4 and 5 that were hyper, and there was one hand where it was 6 and 7 that were hyper. And that matched the limited range of motion. And that matched the mechanism of injury in the accidents. And then I remembered to test C2. She never complains of headaches. She never complains of anything. C2 on the left was, and David Eakes drove down from Seattle, and he's our cameraman. And he said it was really great because before you said anything about it being hyper, you could see her face make faces.
Right.
And it's, you do this and that. And I said, do you have a headache? All the time, only on the left. And I'm like, that's a C2 nerve root. We can treat that. And so then you want to match the physical exam to the history. So if she didn't mark the back of her head on the left, where it's hypersensitive,
right,
and where she always has a headache, she's stoic. And when she says it's a 3, you have to double check and say, if you weren't like minimizing it, what would it be?
Right.
Okay, it's a 5. So it was really fun. It took us about 40 minutes.
Excellent.
5 minutes.
Yeah.
And it would have, the exam itself would have taken less time, but explaining to people how I match the history, the physical exam with the treatment plan.
Right.
So as soon as you finish this physical, you're going to lay her on her back with nothing under her knees because she has an L5 disc bulge on the right and a positive straight leg raise and Braggart's. And so while you're working on her neck, you just put, this physical exam means that you're going to put a contact under her low back, one on her foot. You have a custom care treating 40 and 396, and you have another custom care treating disc repair from back to front. And then you tell her to roll up a towel and put it behind her back so it keeps her in extension. And then you have a towel around her neck. You have another custom care running from her neck to her shoulder, yellow one on C5, and then the other one, the black one, on 6 and 7. And then you did the supine cervical practicum. And then for 20 minutes of that, you part her hair and you go from her neck to the end of C2. And at the end of that treatment, she'll be pain-free. She also has 7 of 9 Baton points, but hypermobility isn't a thing right now. Pain is,
Right.
from the old Ottawans. So we'll do if she was spraining her ankle all the time or doing this or doing that, or complaining about being hypermobile, then you could do 124 and 77, but we'll do that after she's out of pain. Right now, her pain level on the piece of paper was a 3, but in reality, it's okay. It's probably a 5, maybe a 6. Anyway, I had a really good time. That's why I'm wearing a suit and everything.
And I apologize, I'm not wearing a suit, but I'm glad that I'm here, whatever I showed up in.
You look great. And your dog is now been
Resting. Yes.
resting nicely with pain pills.
So let's talk about, I want to talk about Arizona, because I know you got to debrief probably about it without me while I was with some athletes. But what I want to circumflex back to, because it's fresh in my mind, is about pain. And I think one of the biggest questions that we always get is, where do we start? We have so many options. What do I start with? There's this and this. Where do I start with? And I think when you have the history and then you have the physical exam and then you have the pain score, it's putting it together so that you can treat the pain right away. And obviously, if they're in a lot of pain, that's going to be really important to bring their pain down. But pain is pain. And when you have somebody that walks in with a 3, you may think, oh, they're not really in that much pain. I want to go after this. No, you still need to get the pain to decrease, because so much guarding, splinting, altered mechanics happen when there's pain and pain perception. So I think that's a really important point, that you were able to negotiate her pain. Like, you're saying it's a 3, and obviously you know Wendy, but we can typically pick up on the people who minimize their pain.
When you get to the physical exam, when you have that much nerve hyperesthesia, nerve pain hurts. It's bothersome.
Yeah.
And it results in central sensitization, spinal cord sensitization, and central sensitization.
Yeah.
If she had reported her pain at a 6 or a 7, I would have done 40 and 10 and flipped over to 40 and 89 for 5 minutes or so.
Sure.
To quiet the central sensitization. But she's using her midbrain and I can see the picture. I can't remember the name of the part of the brain that's just above the brainstem that produces opium, produces morphine. And it's descending inhibition of pain. You make opium, you make morphine. And she's got 3 kids and a husband that works, and she's got a lot of stuff to do, and she doesn't have time to be in pain.
Yeah.
So she underreports her pain because that part of her brain is suppressing it. So her midbrain is not sensitized. Her midbrain is saying, yeah, you don't have time for this. I'll take care of it. So she reports it as it's a 3 or 4. And then when you get the physical exam stuff, then you can ask how to diplomatically, you can ask, usually nerve pain is pretty uncomfortable. If you had to describe the pain in your shoulder, so you have C4 and C5 both hot. If you had to describe the pain in that shoulder, how would you, and like really look at it? What do you think it is on a 0 to 10 scale?
One of the other, sorry, go on.
Yeah, and that's when she said, it's probably a 5.
Yeah.
Yeah, it's more than a little uncomfortable.
Yes.
It's bothersome if you pay attention to it. You can ignore it when you have to, but it's bothersome if you pay attention to it. So it validates the patient, and you can give them extra points for being tough.
Yeah. With the athletic community and the working moms and the people, like you'd said, who really just don't have time to deal with this, tells you a few things. Yes, I'm in that club, unfortunately, as well. It tells you a few things about their personality. One of the workarounds that when I hear pain is reported a little bit lower than I expect it to, I'll say things like, what is this discomfort that you have? What is it preventing you from doing? And then they'll say, oh, if I didn't have it, I would do this and this. And I'll say, okay, so on a scale of 1 to 10, how much does that irritate you? And then they'll give me a bit of a higher number. And then I kind of work in the middle, because those people who are working moms, who are athletes, who are the type A, just, I don't have time to deal with this, they're irritated by this injury. It's bugging them. And then they get resentful because of what they could be doing and that they have to be there. So I think between all of what you're saying, we have to ask better questions, maybe.
And there are actually forms. So in medicine, sad to say, nobody really cares about your pain. Like, it's not about pain, it's about function. So there's an oswestry that gives you an actual percentage of loss of function. There's a TAOS score, TAOS, and I'm not sure what
Remember either.
what it stands for, but TAOS is what Jody used in the ulnar nerve transposition case that we did. His TAOS score was 86%. And when the PTs finished with him, he was at 91%. 1 year later, he was at 82%.
Right.
Out of 100%, everything's easy. And then when we finished with him, he was at 100%.
Wow.
Full function. And a year later, when we had him fill out the TAOS score, it's just circle the thing. And that was 100% again. So there's pain and there's function. And the other thing sometimes I'll use is there's 2 parts to pain. One is how much it actually hurts, and the other is how much you mind it. So somebody that's sitting there comfortably with a smile on their face and they're all relaxed and joking around, and you ask them what their pain score is, and they've got the X on the 10 centimeter line up at an 8. And it's okay. People that have their pain at an 8 don't behave the way you are. They don't walk the way you walk. They don't sit the way you sit. They don't crack jokes the way they're cracking jokes. So let's talk about how much it actually hurts and how much you mind it, how much it bothers you. Oh, that's easy. Right. It actually hurts around a 4 or 5, but I mind it an 8. Okay. In general, that tells you it's nerve pain. Nerve pain is really bothersome. So can facet joint pain, depending on where it is.
Yeah.
And so it's like, how much does it hurt? How much do you mind it? There's nobody else that I know that has a scale for that.
Yeah.
But I'll write it in the chart notes. And then there's, especially if you're doing anything that's going to end up in court, or anything where you're going to be responsible to an insurance company or your licensing board. You want to do an oswestry on someone that comes in with an injury, or someone who's on work comp, or someone who. So that's when you do, and you have an oswestry in your back pocket. I use oswestry because that was what I was trained on. Physical therapists seem to use TAOS more. So it's, but the fun thing about today was lining up the history with the physical exam, and that determines your treatment. So as soon as you finish the physical exam, you're going to put this patient down on the table, put a towel under the low back, get rid of the pain down the back of her leg because it's just an L5S1 disc, and then treat the nerves in her hand, shoulder and her hands, and then do the supine cervical practicum with your hands. That takes 30 minutes. And it takes about 30 minutes to get the nerves to quiet down, especially the short ones. So you can get all this done in a 60 to 90 minute new patient visit. So it was really fun to get to, because I don't verbalize what I do. What
You
on
verbalize
my head.
You verbalize it, but I think you minimize it because of what you know, but we don't know what you know. It's like that. So
As I'm doing the physical exam, I'm outlining in my head, this is the treatment plan, and this is why I have 4 custom cares and 4 precision cares in this one treatment room, because I only have people for 4 days. But I pretended that I was going to see her twice this week and twice the next week. And my goal, and I'll give you some exercises for the discs in your neck, discs in your low back. And you've had this for 15 years, and I think we can get it gone more or less permanently in about 6 weeks. Are you in for it? And then she leaves with her pain at a 0. Then
I think the important part that maybe you take for granted that you do, but the longer I'm teaching people and I'm hearing questions, the more I really think it's important to give them a plan. So with my athletes, I'll phrase it the short-term play and the long-term play. Like, this is something that they can understand. But same with anybody, really. The short-term gets you out of pain. Let's heal this. Let's put this in place. But the long-term plan should always kind of circle back to, we don't want you to relapse. We don't want this to get worse. We want this to keep getting better and for the pain to stay gone. I always am a bit hesitant using the word cure, even when you know it's a slam dunk. If they follow X, Y, and Z, life gets in the way. But dealing with discs, obviously, yes, the custom care, taking that home and running your disc protocols every night is a huge component. However, we can't just lie there and absorb current. We also need to be doing some exercises and segmentally strengthen those areas.
And it depends on the patient and the physical exam again. So if the patient has 20, so she had 40 degrees of neck flexion, and it should be 60 or 50, right?
Yeah.
And if the patient has like 20 degrees, and that results in instant pain in between their shoulder blades, and both of their hands at 6 and 7 are hyper.
Yeah.
It's like, then the instruction is, I don't talk about cure. I never use that word. I like to fix stuff. So I want to fix this. People have been treating you for 6 years for this accident. I would like to fix this disc. What that means is you don't get to break it. For the next 6 weeks, you have a sprained ankle in your neck, and that puts it in a whole different perspective, because everybody knows sprained ankles get better.
Yeah.
Nobody in 6 years has told this lady that the disc in her neck is fixable. It will get repaired. You have a sprained ankle in your neck. That means that you don't get to vacuum, you don't get to mop, you don't get to lift anything that weighs more than 5 pounds. And they, at the moment, when you say that, their eyes get big and they say, yes, but I have to.
No, but you don't.
Yeah, so here's the phrase. This is the magic phrase. It's not that you can't. For 6 weeks, you're not allowed to.
And that takes that reframe changes everything, because it's those people that have gotten into the situation in the first place have tended to blow through the stop signs and have not stopped and have not taken care of things.
Nobody ever told them that lifting a gallon of milk at the end of their arm is like lifting 30 pounds.
Sure.
Because you take 5 pounds, gallon of milk, and if you hold it right next to your body, it weighs 5 pounds. If you put it on the end of your arm, it is 3 times 5, okay, 15 pounds, right?
Yeah.
But you're not allowed to lift a gallon of milk.
Yeah.
You can hold it here, and the 6 weeks that it's going to take to fix this sprained ankle in your neck, this disc, takes 6 weeks.
Yeah.
When you do something you're not allowed to do, when you mop the floor, when you vacuum, you have a 14-year-old son, he can learn to operate a vacuum.
Right.
He can learn to mop the floor. And the 6 weeks starts over from the time you do something you're not allowed to do. I usually say from the time you do something stupid, but I'm being polite right now. So it's from the time you do something you're not allowed to do.
Right.
It starts over because you just broke it again.
Right.
Oh, okay.
People tend to listen to that. So again, you gave them a long-term plan with some consequences. As somebody making a run for it, I'm like, you're not awake right now. You have a sprained ankle in your ear, so you need to just stop. If only dogs would listen to us as well as humans. But again, you've laid out a short-term plan. This is what we're going to do today. This is what you're going to do tonight. This is what you're going to do in the next little while for exercises. Of course, exercises need to be modified throughout the term, but the lifting is, and the not allowed, that gives people permission to heal as well. Some of us have a hard time not doing something.
Well, and the thing is that for most people, no one ever told them what was going to make it worse.
Yeah.
So it's like, well, can I do X? No. What position does that put you in? Oh, I like going to the gym. You can go to the gym. I love it when you go to the gym. You cannot do this. You cannot do that because weights over your head are pushing down on the donut. Oh, you can ride the bike. You can do things that do this. You can do those little teeny exercises I showed you when you're laying on your tummy.
Mhm.
That will help repair the disc. But the 6 weeks starts over from the first time you do something that makes it worse. Oh, and that's how it is that you've been 6 years at trying to get it better because nobody ever told you not to do that. Oh, okay. Then you're their hero.
Yeah.
And they are more likely to follow directions.
Yeah. They're also going to be more likely to follow directions when the pain stays gone. So then they can see after a short term, oh, you know what, this is actually working. And that also helps that retention and attrition to the plan, because it's like anything. It's like run coaching or personal training. Once people see results, there's a bit more of a buy-in. And so again, going back to the physical exam, that initial treatment, people who are skeptics of me and of microcurrent and of all the things, if I can decrease if they're walking in with a 7 out of 10 and they leave it a 1 or a 2, that's instant. That's an instant buy-in. There's instant results there. So they tend to listen to me after. So that's another thing for the practitioners that are listening. Again, going down to pain. When the pain goes down, people tend to listen to you a little bit more, as opposed to if you don't touch the pain, yeah, maybe their range of motion improves, but the pain has to go down. And then we can deal with the function. And sometimes we can do it simultaneously, but sometimes that takes a little bit.
And it also, if you set it up, that it's like setting up a joke,
Yeah.
you set it up that way and they decide or they forget that they're not allowed to lift the jug of milk off the counter this way and put it in the fridge. They lift the jug of milk, the pain comes back in between their shoulder blades, their hand hurts and falls asleep at night. And she told me that was going to happen.
Yeah.
And speaking of buy-in, we were at the Forum for Integrative Medicine
Yes.
last week, whenever anyway. And we're talking to somebody who has a functional medicine practice, and FSM is good for pain. So they come and they look at our booth and say, so what do you guys got for me? And it's, see the cytokines over there and see that, all that. So you interview the patient and they come in with abdominal pain, bloating, and you take a history. And normally you take a history, make a decision about what they need for supplements or medication, and then you're going to tell them to go home and eliminate these 6 foods from their diet and take about $400 worth of supplements at least, and maybe 1 prescription. So now they're up to a lot of inconvenience.
Yeah.
And you can see their eyes glaze over, and your compliance is, what's your dropout rate? 50%? And most of the functional medicine docs nodded their head. I said, okay.
Is it really that high? Wow.
Oh yeah. The patients are like, are you kidding me?
Yeah.
Eliminate 8 foods that I eat all the time.
Yeah, it's just not sustainable. Yeah.
But you contrast that with, you take the history, you make your decision, and you say to the patient, I know your belly hurts right now. I have this way of treating abdominal pain that's pretty effective, especially for the small intestine and the stuff that you're going on. So what I'd like to do is have my assistant take you in the other room and just run some microcurrent on you. You won't be able to feel it. It just reduces the inflammation in your intestines. And let's see what that does. Okay, so your medical assistant takes them across the room, runs small intestine, whatever. You're seeing another patient. Then the patient that is being treated, they get up off the table a little bit stoned. Their belly doesn't hurt. The bloating is gone. The pain is gone. And then they come over and see you. And you say, now, this is not going to last. In order to get this to last, I need you to avoid at least these 2 things. So no gluten, and I'm sorry, but no milk. Can you do that for a week? And I'll see you next week. And then there's 1 supplement that helps repair your gut wall. It's called butyrate. And you can get it on Amazon. I'm not selling it to you, so I'm not making a buck on it, but you get it on Amazon. And I want you to take 2 of those every night and 1 in the morning. And that will help repair your intestines. And then, yeah, that'll help maintain this. Otherwise, this is going to last about 24 hours and you're going to be back in the same mess that you were before. And you might want to take a digestive enzyme, and you can get that on Amazon, or you can get that at the front desk, so you can leave with that, so it will help you digest your food. And if you've run concussion in Vegas, they're really stoned, and you're running small intestine, so you've got 2 custom cares on them at one time, or your assistant does. And I said, so your compliance rate goes from 50% to 90% to maybe 100%. Because they're out of pain. You ask them to do 2 things. one supplement and I'll see you in a week. So they're not coming in once a month, they're coming in once a week. You get to check in with them, and every time they come in, your assistant takes them across the hall to that empty room that isn't being used for anything else at the moment, and concussion and vagus and small intestine. And you say, how are you doing with your supplements? And how's your belly feeling? It's starting to feel better. And so for a functional medicine practitioner, that's where FSM comes in handy. It's still about pain.
Yeah.
And it's about the maintenance, the stable state. Is it exercises? Is it don't look at the jug of milk? Is it don't eat gluten and corn for a week? And
Right.
then
Yeah.
it makes everything you do easier.
Yeah. Speaking of easier, there's a question and answer that I don't think is going to be easier, but let's chat about it before we go any further.
Yeah.
So, any advice for treating MCAS, possibly been going on a long time in an 80-year-old patient? Tomorrow will be her first appointment. The patient's only giving 30 minutes to try it out. She wants to be treated for inflammation, but won't have time to treat or isn't ready to try FSM for lifelong celiac, or I'm thinking that's hematochromatosis. I'm guessing just typo.
Yeah. Okay.
Other two
So
diagnoses mentioned on a phone intake.
here's you want to, I wouldn't take her.
Yeah.
I wouldn't take her. It's like I would have a conversation with her. So this is, the receptionist is telling you that this is the message. And
Yeah.
do you have the patient's phone number? Okay. So if you have time at the end of your day, you call the patient and you say, number one, why do you think something that you've had for 5 years is going to be fixable in 30 minutes? Is that reasonable? Does that make sense to you? And then MCAS is really complicated. It's not just about the fact that you're itching, it's the fact that your immune system is out of control, your gut is leaking, you're
Yeah.
eating foods that your immune system is aggravated by. FSM will help repair your gut, it'll reduce inflammation. But MCAS, what time of day do you itch the most? Right after a meal. I'm not going to be there tonight after dinner. And these are quercetin you can take. I don't want to spend money on supplements. It's okay, then I don't want to see you as a patient. If you want to get better, you and I have to work together.
Yeah.
And it can't be done in 30 minutes. So
yeah, for me, that was the 30 minutes was what was, if she's only giving me 30 minutes, I have patients that are dying to spend 2 hours with me. And these are the people that I want, people that want to spend time with me. We are a team. And so if I'm getting a gun put to my head, I'm only getting 30 minutes to try it out. That to me just gives me, we all know 30 minutes is not even scratching the surface, especially if it's a new patient.
that's not even time for a history. But here's the other thing. She's 80 years old.
Right.
So she's probably in pain.
Yeah.
She's been jerked around for probably 15 years.
Yeah.
MCAS and digestive issues like this mean that you have joint inflammation. So her knees hurt, her low back hurts, her neck probably hurts, but the itching in the MCAS is driving her crazy. And the last 4 people she saw on her limited financial budget or time budget jerked her around and didn't get anywhere. And so she's like over it.
Yeah.
And so she set her boundaries. She's not going to get jerked around. Us 80-year-olds get a little bit on the cranky side.
And I love my cranky geriatrics that come in to see me. I'll hang with them any day of the week. It's just I'm only given 30 minutes. To me, I book a 75-minute to a 90-minute initial. There's no ifs, ands, or buts. And like you said, by the time you sit down, go through the history, I've even done phone consults first on those really complicated histories because I know that the 90 minutes isn't going to give me enough. That to me, because when you're under that pressure as a clinician, you're bound to miss something.
No, and this patient is not one that wants to get better. This patient is one that wants to jerk you around, and it's not reasonable. Now, maybe she doesn't know it's not reasonable.
Yeah.
And so it might be worth a phone call.
For sure. Just to explain how
They-
FSM works and how the treatment works.
It's
And
a-
trust me,
well,
you're going to love being in my room for an hour because
And how MCAS works, what really causes it, and what do we have to do to get it better? She may think it's like taking a pill. It doesn't
No.
work that way, honey.
no,
So-
it is a life issue. I think the comment was, isn't ready to try FSM for lifelong. Oh, it's for celiac.
Oh, it's celiac. It's seriously, okay, the first thing you have to do is be willing to go off gluten. I had a family member person who was about 84,
Mhm.
and she had, it was either Crohn's or ulcerative colitis. And I had her do the gluten cheek swab, the genetic test for celiac. And she was celiac. It was like, she's gluten sensitive.
Yeah.
And she said, I'm not willing to give up English muffins, and muffins. It's no. Okay, that's your decision. And she died about 4 years later. Now she died at 89, so that's not the end of the world. But they were not willing. So lifelong celiac, telling her to go off of gluten 40 years ago was like a death sentence. There was nothing to eat. Now,
Yeah.
gluten-free products are everywhere. They're on every restaurant menu.
Yeah.
And when you explain what gluten does to the gut, to your immune system, to all of that inflammatory stuff.
Yeah.
It's Carmela, I would give her a phone call and talk to her. And you don't have anything to prove to her is
Right.
the thing. And that's the way she's setting this up. And you can't treat lifelong celiac and hemochromatosis. It's really complicated.
Yeah.
And it can't be done in 30 minutes. So I'm not even gonna accept that as a condition.
Right.
If you want to be my patient, I'll settle for 60 minutes or 90 minutes on a first visit for a patient as complex as you are. It's setting us up to fail to set a 30-minute limit and to not be willing to go off gluten. And I'm not willing to fail. I don't like to fail. I like to get people better. And that is my goal with you. And if that is not your goal, then you and I are on a good match and you should find somebody else.
Absolutely. As much as I love hearing FSM is magic and we're magicians, like, let's be honest, we're really good adjuncts, right? We do not take the place of surgery. We do not take the place of antibiotics. We do not take the place of all the things that modern medicine has gifted us, but we are a fantastic adjunct and can make all those things work so much better. And if I could fix MCAS and a celiac in 30 minutes, oh my God, I would charge a lot more.
Yeah. And I would need a wand like Harry Potter.
Yeah.
Like
you said, we both want to win. I want to win as a clinician. I want to feel good about the treatments and the care that I'm providing. I want people to feel better. Patients need to want to have that absolute same buy-in. Otherwise, I don't think it's a good match.
And it's just fine to say that to a patient. It's like, my intention is to get you better. The limits you have put on this are not possible. And I'm not willing to fail. My goal is to get you better.
Yeah.
And you and I form a team to do that. And that can't be done in 30 minutes. So if that is your hard line, And then you and I aren't going to be a good match, and you need to find somebody else to treat you.
Right.
That's people who give you those sorts of things. I think this is part of being my age and having been through what I've been through, is to recognize when you're being jerked around.
Yeah.
And that's what this is, a setup. And it's she wants you to beg her to come. And it's a lot more productive to say, I don't really need you as a patient, because you don't really, it's just not a good match. You're not a bad patient. I'm not a bad doctor. It's just not a good match.
Yeah.
Nope. Yep. Nope. You can't even do an intake, Carmela. I'm not sure what your specialty is, but somebody that's 80 years old with hemochromatosis and celiac and MCAS, you're not going to get through the history in 30 minutes. That's just, and yeah, if she's already off gluten, you've got a chance. Oh, her daughter's had great results with FSM, and that's why she sought it out. Why is she being such a jerk? Pardon my French, but
Can we just talk about the one statement, hoping to reduce her inflammation? I don't even think, and this is just my limited experience with MCAS, 30 minutes for just decreasing inflammation isn't going to make a dent in it.
not even a little, because it has nothing to do with inflammation. It has to do with macrophages and
Yes.
histamine
Yes.
and all things.
Yes.
Yeah.
Yeah.
Yep.
It's not like a swollen joint or a pulled muscle or delayed onset muscle soreness, all which I am taking measurements. I think I was sending you some pictures of some very cool stuff. But yeah, that is easy to reduce inflammation in 30 minutes. Something like this, again, because FSM really works when you find the driver, and it's not just something that's inflamed. It is this whole very complicated histamine reaction that's,
Especially with MCAS, because
yeah.
the immune system activation, the macrophages means the vagus is turned off. So you're going to have to find out what turned the vagus off, because vagus has as its job to quiet down T cells and macrophages. Well, the macrophages eat the IgG antigen antibody complexes. The macrophages eat them. The macrophages explode and release histamine. There's a whole nother pathway for histamine that can get lit up. And it's not just inflammation in the gut. And so you get her inflammation down in her gut, so her belly's not sore anymore. But then she goes home and she eats whatever she's going to eat and breaks into hive, and her head itches like crazy, and she's not willing to take Benadryl or quercetin or any of the things that she's going to have to do to quiet down the histamine response.
Yeah.
It's a project.
That's a great word. Oh,
Hi, Leif.
I leave you tardy. It's so funny that we have this meeting that everybody has to get to. And I know we don't have a ton more time, but I have to just express my sincerest gratitude to this year's FSM Advanced and Symposium. The people that presented, the case studies, people that attended, all of it was just phenomenal. I was so exhausted after the week of, yes, I taught a lot, but I learned a lot, and it's the conversations that happen in the hallway. It's all of it, but it was more inspiring this year than any other year.
It keeps getting better.
Hands down, absolutely. So if you are a practitioner and you have not attended an advanced in some time, please come next year, because
you know what's happening next year, right?
What?
Usually we have 2 half days for the advanced.
Yeah.
And then 2 days for the symposium.
Yeah.
On non-symposium years, I made it 3 half days for the advanced, and I still don't get through half of it. So somebody in the first row said, would you next year do all of the advanced slides? What that means for me is that I have to actually go in and rewrite them, because I haven't really done that in 15 years. I put this is how you think about things. So the thinking about is the important part. So next year, the advanced is going to be me for 4 mornings, which means we are going to have 4 speakers, or maybe I'll make everybody come to the advanced if we're actually going to do it differently. And then the afternoon is still going to be plenary speakers and case reports.
Mhm.
And I don't know if people realize that this year we had people from England, Ireland, in the room, Canada, India. One of our case report speakers was from India, Italy, Poland, France. That's right. David came from France, and
Germany. You say Germany?
Germany too. I
Yep.
missed that one.
They came to my sports and then they came to you.
Oh, okay. So
Yeah.
there we go. And so we have the whole international community, and we had 140 or so people in the room, and an equal number. So we had 300 people there, an equal number on live stream.
Yeah.
Next year, I'm going to be 79, and this is the last time the only time I'm going to do a 4-day advanced, and the only time in 15 plus years that I'm going to spend the next year redoing the advanced slides so I can get all the way through them in 4 half days. And it's not just the numbers, it's how you think about how the system works. So for Patrick Wood to compress what would have been an hour-long lecture into a 30-minute case report, we had a practitioner where 40 and 89 felt so good. She ran it for 6 hours, and then she ran it the next day for another 6 hours. And on the 3rd day, at the end of 6 hours, she had full body pain. Her cerebral cortex didn't work. She had brain fog. She couldn't think. She ended up moving into assisted living, and it was a total mess. And I didn't understand why. Then they started doing judicious 10 minutes at a time of 81 and 89. And after about 2 weeks, she got better. But Patrick, as a psychoneuropharmacology was his specialty, and we were on the fibromyalgia circuit together. And I had to call Patrick up and said, why did that happen? Oh, because the midbrain it's a dopamine thing, and you have to have dopamine, and this happens and that happens. I said, can you do that in an hour? Oh, sure. And then we had so many speakers and so many cases. I called him back and said, can you do it in 30 minutes? And he did it.
Yeah, it was fantastic.
It made perfect sense. And when you can manipulate the brain, you have to know how it works.
Yeah.
We had stroke patients. It's just, the bar keeps getting higher. So I'm so excited for next year. It was really fun. And this year was amazing. Musnick outdid himself. Apparently, I wasn't at your 3-hour thing, but apparently you outdid yourself. The reports back were like, there was, on a scale of 1 to 10, you were a 15. Yay. Same thing with Musnick.
Yeah.
And then Eduardo and the Dura.
Oh, amazing. Amazing pictures and optics and video, all of it. It was so well done. So well done.
I had food poisoning, so I missed all those things.
You can watch it back.
Yeah, it was fun.
Yeah, there's food poisoning. We had everything at the advanced this year.
It was. And then my little friend, Hannah, that we treated when she was 19 months old, she came to every day of the advanced, every day of the symposium. And her mom, being the good MD that she was, got me Zofran for the nausea. Come on. The Phenergan suppository. And she said, and you need an IV. I do. Yes, you do. So there's a service. They came out and did Myers cocktails.
Yeah.
It was so much fun. I had a whole party in my room. And then I get to watch the videos of you guys being.
Yes. Yes. Again, the conversations that happen outside of the ballroom, in the hallway, at the breakouts, at lunch, at the banquet are really indescribable. And as great as all the lectures are and the slides and the PowerPoints, there's just something about the family that gets to unite, the family reunion. And that's what actually I had said when I was about to leave. Somebody was trying to get it, said, I'm sorry, I'm on my way to a family reunion. I'm on my way to the symposium. And it was just a Freudian slip. But
the community, the FSM community is different than any other meeting that anybody goes to. It's what we hear all the time, because where else at a single table will you get a PT, an MD, a DO, a nurse practitioner, a family nurse practitioner, and an OT and a massage therapist? And it's just, and they all have the patient's best interest as their common theme, and FSM as a tool, and the desire to learn and get better at what they do.
I think that's maybe what it is. I never thought of it that way, is because you have so many different practitioners. We all have a different perceptive and scope and thing that we're good at. And so when you have a patient that presents us something, we all see something a little different. And then that's where like that collaborative learning, because if you were trained as a PT, there's no way you would think about some of the functional medicine pathways that somebody could add in, but you could absolutely use that knowledge to help support the patient in a different way. Maybe that's what I'm so grateful for. So when I do go to continuing education that's strictly like physical medicine, I'm just like, this is boring.
Well, you were the reason that we stopped having 2 tracks. When you started coming, what is it? Has it been 8 years now?
Yes. Yeah.
So it's been 8 years, and 7 years ago, because it was after the first advanced and symposium you went to, it was like, you can't do 2 tracks anymore. It's because all the visceral stuff is what it takes to get the physical medicine stuff to stick.
Yeah.
And that's when I got it, because I had this idea about
2 tracks.
2 tracks, and it's never 2 tracks.
No.
Physical, visceral medicine people need to know that they have to get the pain down.
Yeah.
And that's a physical medicine thing. And nerve pain's really easy. And the supine cervical practicum is really easy.
Yeah. And physical medicine people need to know the visceral component to what they're dealing with.
As long as they're eating wheat and their gut's inflamed and leaking, you're not going to get any place with that low back pain.
No.
Or the knee. It's like, I just love our family.
Yes. Yes. And I have to just go back to Muznek's presentation on long COVID, which wasn't even long COVID. It was like everything. It was life. It was long life talk. Absolutely terrifying. And just so much knowledge. Like I felt like my brain was going to explode. And then I had to throw out all my clothes and throw out all of the other things he told us not to do. And it was a whole thing. But the other thing that I think really is so important about the advanced is the speakers that you have are not just knowledgeable in their field, because let's face it, when the best teachers we typically get are in high school. When we go off to college, we get people who are really knowledgeable, but not necessarily good teachers. I have to say that the lecturers that you have are amazing teachers. Juliana Mortensen, between last year's talk and last year's talk, taking such complex information and making it digestible and entertaining and something that I could absolutely use to describe how FSM works in just a more complicated yet simplistic way.
Exactly. She doesn't leave anything out. It's
No.
all research-based.
Yes.
And she makes it, maybe it's the way she presents it.
Maybe.
She makes it so simple. Even Jerry Pollack this year.
Yes. Another one.
So simple, because I made him go back to cells, gels, and the engines of life.
Yeah.
That Diana Cross sent to me. Speaking of which, Australia. I forgot about Australia.
How could we forget Dr. Cross?
3 people from Australia.
Yeah.
And Diana Cross came up and has continued this obsession with how does 124 and 77 and 40 and 10, how does it actually work?
Yeah.
And I sat there and watched her presentation and went, wow. Yeah. And you have to rethink everything. So I have to go back and watch it again.
Me too.
Yeah.
Thank you for recording it and letting us do that. And my alarm is going off.
I know, it's 4 o'clock already. There we go.
There we go. Well, we both made it. I'm so glad that we did.
Yes.
And everybody who's watching us, thank you for coming.
Thank you for coming.
Always. And
it is, and Teresa, yes, it is the Prairie Aqueduct of Gray.
oh,
there we go.
There we go.
There we go.
That little part. Well, we will see you next week, I think.
Next week. I think we're all in town next week. Yay.
All right.
I miss this when we're not.
I know. This is something I truly love doing. So I'm very grateful for our Wednesdays.
And I'm glad that everybody's here. Thank everybody for coming.
Yes.
And for everybody that watches it on YouTube. Yay.
Yay.
And you have to let us know how the dog does.
I will let you know next week. Thanks. All right, everybody. We'll see you next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.